Hello, my name is Mr. Tangen, and I am the Global Product Manager of Cystatin C here at Gentian. Due to the recent attention given to Cystatin C this year, as the discussion of the race factor for creatinine equations has been discussed, we believe that now is the time to talk more about Cystatin C. First of all, I will give you a short recap on glomerular filtration rate, abbreviated GFR. GFR represents the best overall index of a patient's kidney function, and it is used to diagnose and manage kidney disorders. It's also used to adjust medicine dosing to avoid toxic side effects. So how do we determine GFR? You can do it in one of two ways. You can either use an invasive procedure where you inject the patient with a substance like, for example, iohexol, and then you measure the concentration of this substance in the urine at set time intervals. However, this is obviously a time-consuming method. It's also costly and not without risks for the patients. So therefore, what is more commonly done is to measure creatinine. And Cystatin C is also an option here to use an equation to calculate GFR. What is the difference between Cystatin C and creatinine? Cystatin C is a low molecular weight protein. It weighs 13,000 daltons and is produced at a constant rate in all nucleated human cells, whereas creatinine is about 100 times smaller than Cystatin C, and it is generated from the breakdown of muscles. Both are freely filtered through the kidneys, and the rate of production for Cystatin C is affected by thyroid conditions and the patient's smoking status, whereas creatinine is affected by anything that affects the muscle mass, like, for example, age, race, diet, and nutrition. Cystatin C concentrations correlate very well with GFR, whereas creatinine must decline to approximately 50% of normal levels before the serum creatinine rises above the normal levels. So it is very suitable to add Cystatin C to creatinine for certain patients, and that is when the serum creatinine-based eGFR is unreliable. This could be due to extreme age, either the patient is very young, very old, or pregnant. Also, patients with reduced muscle mass due to diseases, amputees, or spinal cord injuries, and last but not least, due to the patient's nutritional status, as severe malnutrition like anorexia or parenteral nutrition will affect a patient's creatinine level without having affected the patient's kidney function. To demonstrate the effects of muscle mass on creatinine, I will show you this study done at Sick Kids Hospital in Toronto. On the left here, you will see the concentration of creatinine on the y-axis and the age on the x-axis. These are healthy individuals. The female samples are in pink and the male samples are blue. And you can see here that the creatinine levels drop off immediately after we are born. And then as we grow and we become stronger, our muscle mass increases, so does our creatinine levels. And when we reach puberty, you will see here that the boys' muscle mass starts to increase more than the girls, And at the age of 18 and 19, you see that the average muscle mass among boys and creatinine is much higher than for the girls. But for Cystatin C, the concentration again on the y-axis, age on the x-axis, drops off immediately after birth, but stabilizes around the age of 1, and then it remains constant, and it's also the same for girls and boys. There is no difference. So obviously, anybody who has seen a group of teenagers know that we hit puberty at different ages. So therefore, in this area here, it is very hard to tell the GFR based on creatinine equations. Another time when it's using Cystatin C can be very beneficial is when you are dosing drugs. In this case, you want to be as accurate as you can when it comes to kidney function and to have the right GFR. A large hospital in the United States wanted to look into this, so they looked at the dosing of Vancomysin, which is an antibiotic that has a very narrow therapeutic window. And if you dose too low, then there is a risk of antibiotic resistance developing. And if you dose too high, then the patient will have kidney damage and also ototoxicity. And then they compared the standard of care, which was using GFR based on creatinine, which is the blue one here, where they saw that they managed to dose 27% of the patients to the optimal trough levels. But when they introduced the CKD epi creatinine Cystatin C equation, combining both creatinine and Cystatin C, they managed to get the right trough concentration of vancomycin in almost twice as many patients. So a significant improvement in patient care was achieved. What they also saw is that avoiding nephrotoxicity is obviously important, and the effect was significant on the length of stay of the patient. So in patients that had nephrotoxicity, they had an average length of stay of 17 days, whereas patients where this was avoided was down to 14. So 3 days less in the hospital for the patient is obviously very beneficial for both the hospital and the patient. Nobody wants to be in the hospital longer than they have to, and the hospital wants to have beds available and to be able to treat as many patients as possible. Now I would like to talk to you about the advantages of the Gentian Cystatin C assay. As many of you know that there are more than one supplier of Cystatin C assays out there. Gentian has a very long experience with Cystatin C, and it was one of the reasons for founding Gentian back in 2001. And our first product was the Cystatin C assay that we launched in 2006. In 2008, we received the 510(k) clearance from the FDA in USA. And our method was also used to establish the standard material that the IFCC supplies in 2010. And we continue our engagement with key opinion leaders, and this helps us to build our reputation, obviously, but also to help educate physicians and laboratories on the benefits of our assays. In 2020, in May, we had a nice seminar with the American Kidney Fund, where we had some esteemed colleagues from the Johns Hopkins Toll University, University of California, San Francisco, and the University of Michigan, giving their speak on creatinine-based eGFR and the alternative of Cystatin C. We also work closely with Dr. Grubb from the Lund University in Sweden. The Gentian, the Cystatin C assay correlates very well with IHO-XL clearance. And we here have a comparison between IHO-XL clearance measured with compared with creatinine, where you have the IHO-XL clearance on the y-axis and the creatinine concentration on the x-axis. Each blue dot represents a patient sample. The R squared should be 1. Here it is 0.783. And we see that there is some discrepancies here, especially here and in this area for the creatinine versus IHO-XL. Looking at the same samples measured with the Gentian Cystatin C assay, again, the IHO-XL clearance on the y-axis and the Cystatin C concentration on the x-axis. We see a much closer correlation than with creatinine, and you see that the R squared is much more close to the optimal value of 1. You have a value here of 0.957. Obviously, this is important, but also accuracy and precision. This is a study published in 2014 by the College of American Pathologists. They had 4 samples, A, B, C, and D, with different concentrations of Cystatin C. Samples A and B were not assigned a specific value, whereas C and D was. Sample A has a concentration average measurement of about 1.55 milligrams per liter, and each dot here, you can see the spread for the different measurements. You have the Siemens, Gentian, Roche, Diazyme, a group of others methods, and then the average of all are on the right. You see here all the Gentian measurements were very close together in sample A as compared to the others, and when it comes to sample B, which is around 0.3, which is very close to the LOQ, you see obviously that the spread is larger for all methods. But again, Gentian is at least as good as the other methods. So we can conclude that the Gentian method is precise. When it comes to sample C and D, these were both assigned a value. So the correct value here should be 0.97. And you see that the Gentian method measures very close to this, and the others some below, some above, but Gentian well within, very close to the accurate measurement. This sample had a value of, like I said, 0.95, which is in a healthy patient. When looking at sample D, the assigned value was around 2.4. This is a patient that has reduced kidney function. You see that the Gentian assay here is measuring right on the assigned value. And I think that we can agree that the Gentian method is both precise and accurate looking at this study. The last thing I will talk about is the interference. And one advantage of the Gentian immunoassay is that we see less interference compared to mammalian-based immunoassays. There are several things in those mammals that can contribute to interference, and the examples are listed here. Amongst others are rheumatoid factor. Looking specifically at the rheumatoid factor, Larsson et al. Did an analysis of 19 samples that had tested positive for rheumatoid factor and controlled this against 10 samples where the rheumatoid factor was negative. And they saw interference in all 19 samples where the assay used had antibodies from a mammal like bovine, horse, human, mouse, rabbit, or sheep, all had interference, but with the avian antibodies from chicken, there was no observed interference. And obviously, for the rheumatoid factor negative samples, there was no interference there either. So to summarize, the benefits of adding Cystatin C to creatinine will reduce the confounding factors in pre-analytics. It will help avoid the GFR being influenced by food intake, muscle mass, or race. And it could contribute to earlier detection of chronic kidney disease and, of course, the better dosing of nephrotoxic drugs. And I hope after hearing this webinar that you will agree with Dr. Natalie Ebert and Michael J. Sleepak, who published this review article last year in Current Opinion of Nephrology and Hypertension. In conclusion, it is of high clinical relevance to raise awareness of clinical use cases where Cystatin C has clear benefits as a second kidney GFR biomarker. Ignoring the potential additional information gained by Cystatin C testing leads to systematic overestimation of kidney function with adverse impacts on patient care. And for those of you who consider continuing using creatinine alone without the race factor, you should be aware of this publication from the New England Journal of Medicine, published in August 2021. The use of serum creatinine level to estimate the GFR without race or genetic ancestry introduced systematic misclassification that could not be eliminated even when numerous non-GFR determinants of the serum creatinine level were accounted for. The estimation of GFR with the use of Cystatin C generated similar results while eliminating the negative consequences of the current race-based approaches. So please add Cystatin C to your measurements in this case. I would like to thank you for your attention, and I will leave you now with the references used in this webinar and our contact information, which is marketing@gentian.com, should you have any questions or want to talk to us about setting up Cystatin C in your laboratory. Thank you.